The first topic that we are going to do today is celiac disease. Celiac disease is basically an autoimmune disease in which there is hypersensitivity to gluten. Gluten is a protein which is present in grains such as rye, wheat, and barley. So, due to hypersensitivity to gluten, there is an inflammatory or hypersensitivity reaction in gut mucosa, which leads to the destruction of villi which are present in the small intestine. What will happen if there is destruction of villi which are present in small intestine? The function of the villi is that it increases the surface area of the gut, which helps in the absorption of important nutrients such as vitamin B12 as well. So due to hypersensitivity reaction to gluten, it will result in destruction of the villi, which will lead to decrease absorption of important nutrients. So as the nutrients are not absorbed, it will lead to the manifestation of celiac disease, which include chronic or intermittent diarrhea, because the nutrients are not absorbed in the gut. So the manifestation will include chronic or intermittent diarrhea. Fats will also be not absorbed from the gut, which will result in fatty stools. Which we call fat in the stools, undigested fat in the stool will result in stinking and bad smelling stools. Also, there will be abdominal discomfort, bloating, nausea, and vomiting. And as the nutrients are not absorbed, and iron, vitamin B12, and folic acid will also be not absorbed, which can result in iron deficiency anemia or folate deficiency or vitamin B12 deficiency. And anemia will manifest as fatigue. So, a summary of celiac disease: it is an autoimmune disease or hypersensitivity reaction to gluten, which is present in rye, wheat, and barley. Due to hypersensitivity reaction to gluten, there is destruction of villi which are present in the gut or in the small intestine, which will result in villus atrophy, and the manifestations of celiac disease, such as diarrhea, steatorrhea, weight loss, and anemia, which can be microcytic anemia. The most common anemia in celiac disease is iron deficiency anemia, which is microcytic anemia. Or it can be macrocytic anemia due to deficiency of folate and B12. Anemia will manifest as fatigue. What are the complications of celiac disease? As fats are not absorbed, so fat soluble vitamins such as vitamin D will also be not absorbed, which will result in osteoporosis. So one complication of celiac disease is osteoporosis, and continuous destruction and regeneration of gut epithelium will lead to T cell lymphoma, uncontrolled proliferation of T cells in the gut human due to inflammatory reaction or hypersensitivity reaction will result in T cell lymphoma. Osteoporosis and T cell lymphoma are rare complication of celiac disease. The important complication which you need to remember for lab 1 exam is dermatitis herpetiformis. A person with chronic diarrhea and a vesicular skin rash. A person with chronic diarrhea and a vesicular skin rash, which is dermatitis herpetiformis, the diagnosis will be celiac disease. So if someone present to you with chronic intermittent diarrhea and weight loss, then the first thing you will think about is celiac disease. How will you investigate celiac disease? The initial investigation for celiac disease is TTG, tissue transglutaminase. First line investigation or initial investigation for celiac disease is TTG. TTG antibodies, TTG IgA, and endomysial antibodies. If TTG is positive, then the diagnostic investigation or the gold standard for the diagnosis of celiac disease is jejunal or duodenal biopsy. What will we see on duodenal or jejunal biopsy? As there is destruction of villi, so we will see villus atrophy. The second thing that we will see is, as it is a hypersensitivity reaction which involve T lymphocytes, so we will see interepithelial lymphocytes. And the third thing that we will see on duodenal or jejunal biopsy is crypt hyperplasia. Remember that the treatment of celiac disease is gluten-free diet. Gluten is present in wheat, barley, and rye. What are the example of the foods which does not contain gluten? These include potato, corn, and rice. Potato, corn, and rice do not contain gluten. So the treatment for celiac disease is gluten-free diet. But if you are going to do biopsy to confirm the diagnosis, then you need to reintroduce the gluten in the diet 6 weeks before the biopsy. If we are going to perform biopsy for the confirmation of the diagnosis, then we need to reintroduce the gluten diet 6 weeks before the biopsy. Now here is an example. Dr. Khan, can you unmute yourself and read the example? Can anyone read the example?
Is it okay if I read it?
Yes, sure.
So, a 33-year-old male, non-smoker, recurrent and chronic diarrhea for 6 months. His clothing appears to be ill-fitting. indicative of weight loss. His hemoglobin is 11, his MCV is 105. So the most likely diagnosis is celiac disease. So we do endoscopy plus a duodenal biopsy will show villus atrophy. Yeah.
Yes. In this example, a person with chronic diarrhea for 6 months. So chronic diarrhea with weight loss and macrocytic anemia because HB is 11 and MCV is 105. So these three hints are pointing towards celiac disease. Now, other causes of chronic diarrhea. One we have discussed, and that was a celiac disease. Now, some other causes of chronic diarrhea. They are Crohn disease and ulcerative colitis. How you are going to differentiate, or what are the points in Plab 1 exam that will point towards Crohn disease, and what are the points that will point towards ulcerative colitis? Crohn disease and ulcerative colitis. First of all, let's discuss something from their names. Ulcerative colitis, as its name indicates, it's basically a colitis. What is colitis? Inflammation that involves colon. There is ascending colon, there is transverse colon, and there is a descending colon, and there is sigmoid colon, and then there is rectum. So ulcerative colitis mainly involves the colon or large intestine. Most commonly, it involves transverse and descending colon. While Crohn disease involve anything, it can involve anything from mouth to anus. But most commonly, it involves terminal ileum or ileocecal junction. So these are two general points which will help you differentiate between Crohn disease and ulcerative colitis. That ulcerative colitis most commonly involve descending colon and sigmoid colon and rectum. So if someone present to you with chronic diarrhea and pain in the left lower quadrant of the abdomen, chronic diarrhea with pain in left lower quadrant of the abdomen, then what will be the diagnosis most probably? Anyone?
Crohn's disease.
Crohn disease involves ileocecal junction or terminal ileum, which is present in the right quadrant of the body. So chronic diarrhea with a pain in left iliac fossa or left lower quadrant of the body will be ulcerative colitis. See, you can tell the diagnosis by just from the location of the pain along with the diarrhea. So I'll repeat this point again. Ulcerative colitis, as it's a colitis, so it will involve colon, ascending colon, transverse colon, and descending colon, and it most commonly involve descending colon, which is present on the left side of the abdomen. descending colon, sigmoid colon, and rectum. Descending colon and sigmoid colon are present on the left side of the abdomen. So as ulcerative colitis most commonly involve descending colon, so someone with chronic diarrhea and left iliac fossa pain, the diagnosis will most probably be ulcerative colitis. But if someone present to you with chronic diarrhea and right iliac fossa pain, then it will be Crohn disease, because though Crohn disease can involve any part of the gastrointestinal tract from mouth to anus, but it most commonly involve ileocecal junction or terminal ileum, which is present in right iliac fossa. Ileocecal junction, the region where appendix is also present. So ileocecal junction is most commonly involved by Crohn disease. So someone with chronic diarrhea and right iliac fossa pain, then the diagnosis will be Crohn disease. So that's how we can tell the diagnosis by just looking at the position of the pain or location of the pain. Anyhow, let's discuss other important points that will point towards Crohn disease. So remember that in Crohn disease, both are example of Crohn disease and ulcerative colitis, both are an example of inflammatory bowel disease. There is inflammation of the bowel. In Crohn disease, the inflammation is transmural. What is a transmural inflammation? The mucosa of the gut consists of 5 layers. The innermost layer is mucosa, then there is submucosa, then there are 2 muscular layers, then there is serosa. Transmural inflammation means that it involves all the layers from mucosa to serosa. So if the inflammation involves all the layers from mucosa to serosa, what will happen? Fistula will form. So by this point, you can remember 2 things, that in Crohn disease, there is transmural inflammation. So on colonoscopy, you will see transmural or deep ulcers. While in ulcerative colitis, the inflammation is only limited to mucosa, the innermost layer. So in ulcerative colitis, there will be superficial ulcers. The second finding that you will see on colonoscopy will be skip lesions. What are skip lesions? Skip lesions that there will be inflammation of some area of the mucosa, then there will be normal mucosa, means some part of the mucosa will be skipped. So the second thing that you will see on colonoscopy is skip lesions. Skip lesion will result in cobblestone appearance of the gut mucosa. Does any one of you have ever seen cobblestones? Or you want me to show you a diagram of cobblestone appearance? Okay, so the colonoscopy finding, I'll show the diagram in a minute. The colonoscopy findings of Crohn disease in Crohn disease there is transmural inflammation. So on colonoscopy there will be deep ulcers, skip lesions, and cobblestone appearance. Just a minute. Diagram of cobblestone is on the way. So this is the diagram. Now look at this diagram. In this diagram, suppose this is the ulcer that we are talking about, the transmural inflammation which has resulted in a deep ulcer. The black lines are deep ulcers. Then an area is skipped. Then again there is an ulcer. So because of this pathology, that some regions of the gut is spared, it results in a cobblestone appearance of the gut mucosa. So on colonoscopy, you will see cobblestone appearance and deep ulcers or skip lesions. Is it clear to everyone? So we are talking about differences between Crohn disease and ulcerative colitis. In Crohn disease, as there is transmural inflammation, so on colonoscopy you will see transmural or deep ulcers, skip lesions, and cobblestone appearance. While in ulcerative colitis, what will be the finding of colonoscopy? As I have told you earlier that in ulcerative colitis there are superficial ulcers. So on colonoscopy in ulcerative colitis, you will see superficial ulcers. Now the second difference between these two is on the basis of histology. Remember that in Crohn disease, there is a granuloma formation. In Crohn disease, there are granuloma formations. Non-quiesceting granulomas are formed in Crohn disease. So in histology, we will see granulomas and increased goblet cells. Goblet cells are basically mucus producing cells which are present in columnar epithelium, and whole of the GIT except esophagus is lined by columnar epithelium and they contain goblet cells. In case of Crohn disease, because of inflammation of the gut or mucosa or columnar epithelium, there is an increase in the goblet cells and granuloma formation. So in Plab 1, they'll give you a scenario that a person present to you with a mass in the right iliac fossa and chronic diarrhea. mass in the right iliac fossa, and chronic diarrhea. Just a reminder for all of you that meeting will end in 10 minutes. You can join again through the same link. Yes, Crohn disease, because Crohn disease most commonly involves the terminal ileum or ileocecal junction, which is present in the right iliac fossa, and Crohn disease can also lead to granuloma formation. So if in the Plab 1 exam they ask you that a person with a mass in the right iliac fossa and chronic diarrhea, then you will think of Crohn disease. What will be the finding in ulcerative colitis on histology? In ulcerative colitis, there will be crypt abscesses and a decrease in goblet cells. So colonoscopy difference we have discussed, and histological difference between Crohn's and ulcerative colitis, and the difference of the part of the gut that is affected by both of them. Up till now we have discussed three differences. Now the fourth difference is on the basis of sign and symptoms. The diarrhea in Crohn disease is usually non-bloody, and weight loss is more common in Crohn disease. While in ulcerative colitis, the bloody diarrhea is more common. Because ulcerative colitis involves colon, descending colon or sigmoid colon or rectum. So if there is inflammation in the rectum, there will be bloody diarrhea. While in Crohn disease, because Crohn disease most commonly involves small intestine, and if there is inflammation in the small intestine, uh, the blood when it reach the rectum or anus, the blood will just disappear or digested by the enzymes. So in Crohn's disease, the diarrhea is usually non-bloody, and because it involves small intestine and small intestine is associated with the absorption of important nutrients, so it will result in weight loss in Crohn disease. While in ulcerative colitis, the diarrhea is usually bloody and a weight loss is uncommon. As I have told before, in Crohn disease, the inflammation is transmural, so it will result in the fistula formation. So someone with a chronic diarrhea and fistulas, perianal fistulas, again your diagnosis will be Crohn disease. A person with primary sclerosing cholangitis and chronic diarrhea, your diagnosis will be ulcerative colitis, because primary sclerosing cholangitis is more common in ulcerative colitis. Then there is the third symptom, oral ulcers. Remember that oral ulcers can be seen in both Crohn disease and ulcerative colitis, but it is more common in Crohn disease. Some of you can remember there was an MCQ in the November Plab 1 regarding a scenario which were confusing. Students were confused among Crohn disease and ulcerative colitis. Inflammatory bowel disease is a favorite topic of Plab 1. There is always one or two questions from this topic. So the other difference is, remember that smoking increases the risk of Crohn disease while smoking decreases the risk of ulcerative colitis. So for ulcerative colitis, smoking is protective, while for Crohn disease, smoking increases the risk. So We have discussed all the differences between ulcerative colitis and Crohn disease, colonoscopic differences, histologic differences, differences in sign and symptoms. Now, the treatment, remember that the gold standard investigation for the diagnosis of inflammatory bowel disease is colonoscopy. Gold standard investigation for the diagnosis of Crohn disease or ulcerative colitis is colonoscopy. So colonoscopic differences, histologic differences. Now there is one more difference which is based on the basis of barium enema. In ulcerative colitis on barium enema, there will be loss of ostration. Large intestine usually have normal large intestine or colon usually have ostration, which are lost due to inflammation in ulcerative colitis. So on enema, barium enema, there will be loss of ostration or lead drain pipe appearance. The large intestine will appear like a drain pipe. While in Crohn disease, what will be the finding on barium enema? String sign. Small intestine will just become like a string, a thread, a small narrow thread, and because of deep ulcers, the appearance of the ulcers will just like be thorns on enema. So the differences between ulcerative colitis and Crohn disease can be divided into 4 categories. One is colonoscopic differences, second one is histologic differences, third one is differences on the basis of barium enema, and fourth one is difference between the sign and symptoms. The gold standard investigation for the diagnosis of inflammatory bowel disease, ulcerative colitis, and Crohn disease is colonoscopy. Treatment of Crohn disease and ulcerative colitis. Remember that there are 2 types of drugs which are used in the treatment of inflammatory bowel disease. One type of drugs are used to induce remission, and the second type of drugs are used to maintain remission. In Crohn disease, the first line drug to induce remission is different than ulcerative colitis. In Crohn disease, the first line drug to induce remission is oral prednisolone or oral steroids such as prednisolone. While in ulcerative colitis, the first line drug to induce remission is 5-aminosalicylic acid derivatives such as mesalazine. Both prednisolone and mesalazine are anti-inflammatory drugs. They inhibit the inflammation, so they can be used in Crohn disease and ulcerative colitis. For Crohn disease, the first line drug to induce remission is prednisolone, while in ulcerative colitis, the first line drug to induce remission is mesalazine. Crohn disease start from C, so the first line drug for Crohn disease is corticosteroids or prednisolone.